Let's get started. Our guest speaker today is Dr. Larry Fisher from the University of California, San Francisco, Department of Family Medicine. He's now Professor Emeritus there, but still has an active research group going. I met Larry in 1983, 84, something like that. And just to date him a little bit, he was a key member of my dissertation committee. I'm 66.
Three.
Larry was a tremendous mentor, and one of the key things he taught me, been valuable throughout my academic career, is that science is not a lone science operation. It's teamwork, it's collaborations. For instance, Larry's been collaborating with Russ Glasgow here for 20 years, and I had no idea whatsoever until just a few weeks ago. But you'll see some of Russ's ideas coming out and the things that Larry has to say. Collaborations are of that nature. You build on lots and lots of different things. Working in primary care settings is also a significant collaboration, and Larry's going to be talking about that today and some of the challenges. So before I turn it over to you, Larry, I just want to thank Marie Harvey and the Dean's Office for paying for all of this. It's really much appreciated by everybody. And after that, Larry?
Hi, all. There's rooms up here. Well, okay. Can you hear me? Is the audio's okay? Yeah? Okay, I think we're good. Thank you. What I'm going to try to do is I'm going to shoot for 45 minutes, and then so we can have some time to kind of interact a bit about this. So let me begin by thanking Peggy and Joe for the invitation. It really is a delight to come up here and meet some people and see the area and drink some good wine. It's really good. The invitation came at a time where multiple things converged, and actually there were three major conversions, so it's really timely. The first is about 2 weeks ago, our team from Colorado and San Francisco, it's a collaborative team, met to review the results of a 5-year implementation trial. And we were and have been inundated with data from this project. So the issue of implementation and dealing with data is really fresh, and it's kind of stuff kind of reverberating in my head. So that it was really timely to do that. And secondly, for the last 2 months, I've been rereading a lot of the implementation literature in preparation for looking at these data. And it's really kind of brought me back in touch with a whole mess of stuff that I forgot, because I hadn't seen it and it wasn't really in the front burner. So that's been really helpful. And at the same time, and the third convergent point is that now that we've got these new data and we're kind of processing it, we're beginning to think, where do we go from here? Given all the literature that I've been reading, the current data that we're getting, knowing where you've come from really helps inform in lots of ways where you might want to go next. And so that's been a very interesting exercise. Of course, reflecting back on where you come from can be problematic, as you'll see here, where one of these folks say, I never pause for reflection, it's always such a disappointment. So, it's you got to be careful, kind of doing that. What I'd like to do, though, for today is to share some personal experiences regarding strategies for implementation, and, as I said, where we might want to go from here. And to do that, what I'm going to do is to review with you the results of 3 different implementation trials with which I've been involved over the last few years, several years. And I've been involved in different ways in these. And then what I'm going to do is to use these trials and the data from them to kind of share with you some perspectives, some points of view, some observations about where we might want to go and how we might think about this. Two issues to raise. First off, this will not be a data-driven presentation. Okay, you will not see a statistical test. You will not see a number. There will be no data charts. You can relax. You don't have to I got to process all this. These studies are really only a means to an end. So I'll describe them. I'll make a descriptive presentation, and the results will be descriptive. Second point I want to raise is that since 1986, I think it is, I have been in a primary care department. I see patients through primary care. I'm a clinician, and all of my research, or most of it, has a primary care lens. Most, if not all of you, from what I understand, come from a public health or community-based orientation. You see the world through that lens. And so my experiences here may or may not coincide with your experiences in this other realm. I will bet you dollars to donuts that there is a huge amount of overlap in the issues involved, quite clearly a lot of distinctions. And it's where we have that convergence and difference that'll be interesting to hear about. And that's why I want to get some feedback from you about how much this really applies to what you do, how you would see it differently, what are the issues from your perspective. So with that, let's do a little bit of history just to kind of set the stage. In the 1980s and 1990s, we saw a huge shift in the healthcare system as we move from an acute care to a chronic care model. And what kind of emerged here are, all the kinds of things you know about the development of the chronic care model, PCMH. And in 1999, some dude named Glasgow published this funny stuff with 5 letters called REAIM. And REAIM really set the stage for implementation research by, in a sense, structuring some of the targets and directions that we need to be aware of as we engage in this kind of endeavor. And by the way, Russ, if you haven't met Russ, he's sitting here, and he's a good guy to meet. Definitely should do that if you have a chance. What happened here? Did this get merged? No, it didn't. I was worried about 2 slides getting prompted between, but it's okay. What happened here, unfortunately, was a kind of realization. In 2001, the IOM, Institute of Medicine, published the Quality Chasm Report. And this little quote here probably is the most quoted. You see it all over the place. It's highly quoted. It says, between the healthcare we have and the care we could have lies not a gap, but a chasm. That's 2001. And I would suggest that that chasm is as wide now as it was then. I mean, we've made some huge strides, so I don't want to be pessimistic, but the issues still remain, and they're really important. This whole movement accelerated the need to translate bench to bedside knowledge. So we had a lot of programs that we knew worked in healthcare, but most of them were sitting up on a shelf, and they were never kind of brought down into the real world of care to actually operate in the real world of care. And these 4 quotes I really like, and I use them a lot in presentation. After we got to the notion of translating stuff that was up on the shelf into the real world, we found that to see far is one thing, but going there is another. And these 3 quotes are kind of trying to set the stage and keep us in perspective. Perry Dickinson wrote this in 2014 as he published a study, and he said adoption and maintenance of core programs into primary care have been disappointing. This was in 2014. In 2004, this statement by Burns, in fact, some estimates indicate that 2/3 of healthcare organizations' efforts to implement change fail. That's a shocker. It kind of leads you somewhat pessimistically. Let's not dwell on the pessimism. Let's just dwell on the reality. And this was just published 2015, and I'm much more familiar with this. Aziz et al. Say that achieving better translation of these, and these are the DPP. Everybody know the DPP, Diabetes Prevention Program? It was a big program to prevent diabetes from those at risk, quotes, pre-diabetes. Achieving better and it worked, by the way, and it's really a good program. But achieving better translation of these programs still remains challenging after 15 years of research. So the implementation is not an easy task. And I would suggest there are 2 main problems that really typify. There are actually lots of problems that make it hard, but these are the two that I kind of respond to. And the first has to do with, if you'll see the guy over here on your left, is offering these folks a round wheel to their square wheels and one guy said no thanks, and the other one says we're too busy. And this is a kind of joke, but on the other hand, it's really true. Why is this? Because the institutions we work with have a huge number of competing priorities. Many of them their survival is challenged constantly. And they just don't have the bandwidth. It's not that they're unthinking and they don't want to do things. There are real major problems to enable them to actually do it. The second problem that I think is really important is implementation is not always a guarantee. I don't know how many primary care practices I've gone into and talked with the powers that be about a particular program, and they come on, we really need to do this. It fits with our mission. This is something, let's get this started. And then a month later, you're still waiting for the meeting with the principals. You try to get folks together, and then this one doesn't show up, and this one. So just because a clinic director or a public health department leader or a community-based organization person says to you, yes, we're going to do it, there are no guarantees. There are backs and problems all along the line. And again, it refers back not that these people don't want improvements and change and think it's a good idea. It's that they're systemically restricted for lots of very good reasons. And hence emerged implementation science, given this reality. There are two goals, I think, to implementation science, and I'm following my colleague Dr. Glasgow's point of view here. Implementation science asks us to consider how we can help healthcare systems implement and maintain use of efficacious programs, as well as the other three REAIM criteria. And the second goal is basically an evaluative one, to perform formative evaluations to assess the extent to which implementation is effective on a specific context to optimize the benefits of the intervention. So the goals are to help adoption and implementation happen, and then to measure its effects. And I will suggest to you, after doing this with Russ and with others for many, many years, that achieving these two goals is really, and if you'll pardon the extra, really hard. This, of all the research activities I've had over my career starting at age 3, is I will admit this is probably the hardest set of tasks. So you're not entering something that's a piece of cake. It's challenging and fascinating and interesting, but it really is very hard. So with that as preamble, a little history, a little background, let's start with 3 studies, okay? And again, I'm going to only do this descriptively. The first study is called FluFit. FluFit, and this is a screenshot from their website. By the way, if you have a chance, write it down, flufit.org. Take a look at it. It's really neat. So FluFit was developed about 2009, 2010 by 2 guys, both family physicians in my department, Mike Potter, whose office is literally next door to mine, who is a clinician and a clinical researcher in our department. And the second guy is a guy named Larry Dickey, who's also in our department, but he comes at it, he spends a lot of his time in Sacramento in the State Department of Health. And his interest, both their interest, was how can we increase the rate of colorectal screening for cancer? And if we have a chance at the end, I'll tell you how they came up with this fascinating. It's the law of propinquity. They didn't know this. See, a behavior science like me, scientists would know that. But they didn't know that if you have a low-frequency behavior and you have a high-frequency behavior and you want to increase the low behavior, if you can maintain the frequency of the high-frequency behavior and couple them, you'll see the other go up. That's the law, behavioral science law of, isn't that a great word? Propinquity. I love that word. Anyway, so here is what FluFit is. Really neat. And I'm going to have to read it because, can you read it? No, you can't. Okay. My God, it's the background. FluFit is an award-winning and research-tested program that helps healthcare teams increase colorectal screening rates by offering fecal immunochemical tests, FIT, fecal immunochemical tests, to eligible patients during annual flu shot campaigns. Neat, huh? Successful FluFit programs have been implemented in primary care settings across the United States. So here was the idea, clever. All practices have some kind of flu, FluFit, some kind of injections for flu, you know, vaccinations for flu. How many got your flu shot? Ah, see? Very clever. If you're going to go in for a flu shot, wouldn't it be neat if they gave you one of these little packets to test and screen for colorectal cancer? You know what those little you know what they are, the fecal occult? Okay. It was a perfect linkage. Why? Because the people who come for the flu shots, are usually the same people who are at risk for this and need the screening. So if you can put them all together, great idea. So this is a program of low complexity, an intervention program, and it was not asking a practice to do a lot. And here's what was required. It may look like a long list, but frankly, it really isn't much. So a practice, a clinical setting, would have to select somebody to do it. One of the nice things is, whoever's doing the flu shots could easily do this. And that could be an MA, medical assistant, it could be a nurse, it could be a pharmacist. Certainly isn't going to be a doc. Doc's not going to do this. You don't need a doc to give a flu shot. So the docs loved that because it was nothing they had to do. You're not adding on to their work. Not only that, you weren't tied to a specific person. Anybody giving a flu shot with a little education could take care of the pack. Okay? The age and gender of the individuals involved for flu shots, same as risk for colorectal cancer. The MDs only had to give an order. Anybody coming in for a flu shot, I give permission to do that. They didn't have to write an order specially for each person. Docs loved that. Nothing. They didn't have to do anything. There was minimal staff training. Just have to educate this person about what this is about, what kind of questions to expect, and give them the packet. The kits had to be stocked where the flu shot was, quite obvious. And what happened is in these little packets is they go home, you go to the bathroom and you do the smear, put it back in there, send it off to the lab, you mail package, the results come back to the practice, okay? And someone had to be there to get that information and record it in the EHR and to follow up for patients who had a positive screen, which isn't anything that much different than they do when you go to the lab to get a blood draw and they send the results back. You have to have somebody monitoring that. So that function was clearly set up already. And then some kind of follow-up for the non-returned kits and information. Make sense? Everybody following? That's not a lot of work when you think about it, and it fits into what people are doing anyway. Here are the results of the program. Significant increases in the rates of screening from 18 to 48%. That's not 100%, but that's a huge, huge increase. After 1 year, 63% of clinics continued using it, and of these, 85% added a mailed packet. In other words, they called patients and said, hey, I'm sending this to you, all right? High staff satisfaction, was easily organized, didn't need an MD order, and this was really interesting on REACH. These folks started thinking about other things they could do around prevention, like mammograms. Folks come in, you're seeing them for the flu shot. If they're on the list, here's an appointment for a mammogram, right? So that it's spread. There was a reach. There was a broadening of the prevention perspective. The lens began to open up a little bit. And it's now actually CDC recommends it, American Cancer Society. Insurance companies love it because it's low cost. It can actually be reimbursed in some cases. Kaiser uses it. I mean, this is a really well-used, wonderful program. And Mike and Larry are really happy people because this jump-started a whole mess of American Cancer Society's funding for related programs. You get one that works, wow, you're in the driver's seat for some more. Why was this program implemented so successfully? Okay, it's really simple. It's easily organized and staff is easily trained. Any number of staff, it's not restricted to only docs or only nurses. No demands on physicians. Biggie. Big. Russ is going, yeah. No demands on physicians. Requires no special training or practice or system changes. We don't have to realign people and change patient flow issues. Highly valued. Prevention in primary care. Are you kidding? That's really important. Very low cost, could be reimbursed in some cases. And it easily influenced all 5 of the REAIM criteria. So it's easily documented, and with that kind of ability, it's spread in these communities. Now here's a big but, that's why I put it in yellow. Maintenance across clinics was not 100%. Not all clinics did it, continued doing it after the project was over. Many did, but it wasn't 100%. The number of eligible patients potentially that could have been enrolled in this, it was not 100% either. So even with this really wonderful, clever, just really creative program, you didn't get all the clinics you wanted, and you didn't get all the patients you wanted. Did it make a dent? A huge dent, no question about it. But keeping things in perspective, it did a lot, didn't do everything, but a lot is better than nothing. And it did have a big effect. Study number 2. Okay? This study is called Enhancing Practice, Improving Care, EPIC. Isn't it great? I mean, the next one is called CTH. It's an alphabet soup of letters. Yeah, everybody. And by the way, the sophistication of your intervention is directly proportional to the cleverness of the algorithm, right? Now, if you don't have a good one, forget it. It's not going to work.
I thought that was inverse.
Inverse. No, well, maybe. You never can tell these days. That's right. Okay, so this EPIC was completed about 4 years ago, something like that, in Colorado. It was headed by Perry and Miriam Dickinson, long-term friends and colleagues of mine. So I was involved with this from the very, very beginning. And it took place completely in Colorado. And if you go through the list of names, if you can see them all, there's some really implementation heavy hitters here. That includes, Paul Nutting and Ben Crabtree, really, primary people in the implementation movement. Very smart, very creative people. So I was an investigator here with some really sophisticated folks. So it was really fun. Had a chance to learn about it and about the whole process. The goal of EPIC is as follows. The goal was to compare the effectiveness of 3 different approaches to enhancing adoption and maintenance of the chronic care model. Everybody familiar with the chronic care model? Yes? No? Okay, chronic care model, very, very quickly. Ed Wagner and Dr. Glasgow's very creative approach. This was an effort to switch from an acute care model to a chronic care model. What do you need for good chronic care? A whole bunch of criteria, from team care to self-management support to well-documentation, It was an attempt to reorient the healthcare. Is this fair to say, Russ? Kind of reorient things to focus on a set of clear criteria that would underlie what it would mean to deliver good chronic care in primary care. Is that fair? Would you add?
Yeah, I might even add best practices. That was the precursor of evidence-based.
That's right. That's
that
right.
wasn't established yet.
Right. So that makes sense, everybody, because we were switching from an acute care to a chronic care model, and we really needed to kind of have some foundation for what we were shooting for. And
since you had me interrupt you already, parenthetically, I think 2 things about that are still relevant and challenging today. One of those was self-management, which Larry has spent his life doing. The other one that you all know a great deal about and is done the least often is community linkage to community resources.
That's right.
Real, bona fide, ongoing quality linkages.
Which happens. Yeah. Exactly. Okay, so the idea was, could we help practices implement the chronic care model? It sounds vague, but I'll narrow it down into some specifics, in a way that would work and be sustained, that they could implement and maintain. Those are the 2 of the REAIM, adoption, implementation, and REAIM. As far as I'm concerned, because I'm way back in the sequence of things, that's the most important for me and the most difficult for our group to deal with. So we collected measures based on staff interviews and surveys, and then we did a whole mess of chart audits to see whether or not what we were trying to implement indeed occurred and if it affected clinical outcomes. And we did that through chart order. The outcomes were the ADA Physician Recognition Program criteria. There are 9 of them, and you can see them listed, and one of them at the end is SMS, provision of SMS, that's self-management support. So what we were doing in the chart audit is to see the documentation of these kinds of criteria and to see if they changed over time at baseline, 9, and 18 months. Okay? Everybody with me so far? Here are the 3 arms of the study. The first arm was self-directed. Basically what we did, you know what academic detailing is? Did you ever hear that phrase? Some have? Okay, the old reps from the pharmaceutical industries, they would come at lunch and bring a big spread to a primary care practice. And they'd sit, and everybody would come in and munch this great food, okay, which they would pay for, of course. And during that time, they would hand out brochures and inform the primary care practice of what their company was now introducing, in the new medication, a new device, a new something or other. They would inform them, and they might come back later in a couple of other weeks and do the same thing to remind, in the hopes that with this education, they would make use of it. And that actually makes sense. It's informative. Many of these folks would have had no other route for learning about it. And it was a way, they were marketing. Frankly, they were marketing their product. And that's what we were doing. What we did was to basically provide these individuals a lot of information on the chronic care model and how to adopt the chronic care model for diabetes in their practice. We gave them a website. We had all kinds of stuff, as whether written material, and we said, came back once or twice to make sure they got it all, and they said, go for it. You're on your own. That was it. That's the intervention. Okay, self-direct. They had to take it and make use of it in a way that would make sense. Group number 1. Group number 2 was exactly the same, except we did one other thing. We established in each of these practices what we called a practice facilitation group, and basically a practice improvement group. It was a CQI group, and we provided a practice facilitator to come and work with the practice around selecting chronic care model goals and implementing. How are you going to do this? You want to make sure everybody gets an A1C when they come in with diabetes? Oh, who's going to do it? Who's going to get the results? Who's going to feed it? You know, very specific. And the way we did that is by using PDSA cycles. PDSA cycles? You know what they are? Plan, Do, Study, Act. It's just it's a quality improvement methodology for you plan for something, you do it, you measure it, and then you change it if it doesn't reach the criteria. You learn from the process, and then where you run into stumbling blocks, you change it. It's just it's a CQI technique to help you go from A to B to achieve your goal. And then we help them develop some quality measures to monitor the 9 criteria from the recognition list. Okay? Make sense? That's group number 2. Same as group number 1, but they got a practice facilitator to help them structure and work through the tasks, get the job done. Group 3 got all of what group 2 got. Group 1 got the education, and they got all of what Group 2 got, except the practice improvement team got something different than in Group 2. Group 2 got a CQI approach. In Group 3, we called them RAP Group, which is called Rapid Adapt Systems. This group focused on the practice improvement team, looking at their own practice as a system. The goal of the group was to enhance practice change capacity. And the notion here was, look, if they can improve their communication, their team care, their structure of organization, their culture in ways that would facilitate the adoption and uptake of this program, then they've enhanced their capacity for dealing with change and they can move on. So we were really trying to push the system, practice system. The target here was the practice system. And they addressed issues like culture, communication, problem solving, organizational learning, and orientation to change. And they met 5, 6, 7, 8, 9 times with this practice facilitation group to get them to focus on that, with an idea that once they moved along, they would use the chronic care model criteria as a way of demonstrating the changes they were making as a function of the system approach. Practices established their own chronic care model, changed priorities, but with the ADA goals in mind. Here's what happened. Everybody now got the three groups: education, self-direction, CQI groups, RAP groups. The two groups, very different orientations. Let's find out what happened. Yeah. Okay. It was a cluster randomized design. We were randomizing practices, not patients. We randomized them into the three arms. They weren't fully randomized because they were urban, rural, large, small. We wanted to make sure that we had equal numbers of these different kinds of practices. It was more of a stratified. But once they got into the stratification, they were then randomized. What we found was, in terms of the 9 criteria, which are the primary outcomes, the CQI group, number 2, actually did better than either of the other two groups, which kind of doesn't surprise us in reflection. Actually, the RAP group, group 3, actually did worse than the other two groups, even though they had practice facilitation targeting their system. There was no substantive change in practice, change culture in any group based on the staff surveys and interviews. And even though we were targeting the practice as a system, we saw no change in practice culture, at least as reported by staff. Most of the improvements we saw in the ADA criteria occurred by 9 months, but were sustained at 18, so you didn't see a reduction over time. But even with this improvement, care was still suboptimal at 18 months. So even though we kind of shoved them along and it really didn't meet the ADA criteria by 9 months. Changes in process of care variables did not translate to clinical variables. So even though we saw the ADA improvements in the ADA criteria, you did not see any change in A1C, blood pressure, or cholesterol. Okay? I put these next to in italics because I want you to pay attention to those. Smaller and more rural practices did better than others, regardless of study arm, because they were under-resourced to begin with. This is the one I love. Practices with higher initial change culture scores and with previous CQI experience did far better than those practices, the other practice. The reason I put this in italics is it's not one size fits all. How a practice enters into the program, their experience, the nature of them, where they are, their structure, how big, all kinds of things really influences the implementation process. Practices with greater variability in staff survey responses did poorer than those with more consistent staff. That is fascinating. Everybody follow that one? So if you have 50 people on the staff, the variability of responses to the survey was predictive of how well they would do. And that would make sense. Not what they said, it's just the variability of them. And what's fascinating about that is they're not cohesive. They're not seeing the world through the same lens here, even though they're working in the same culture, in the same practice. Fascinating systemic issue. And the kicker here is, even with the improvement in the change, the criteria, the ADA criteria, the CQI and RAP groups stopped after 9 months. Done. Project over. Goodbye. Thanks very much. See you next time. Okay? No maintenance. No maintenance. Boy, did that hurt. We put all this work into it. Okay. Why the mixed findings? As you can see, this intervention is far more complicated and complex than FluFit, right? Quite clearly. The CQI approach seemed best because it was relatively more focused and structured and targeted. It required staff to do things differently, and both of the groups 2 and group 3 really required staff to do things differently. And when you require staff to do things differently, other than just small tweaks that fit nicely into what they're already doing, it requires some systemic change. And that's where you get a lot of pushback. A lot of staff, even though we spent a lot of time, didn't get it. They just didn't get the idea of what was behind this, that it wasn't that what they were doing was absolutely what the concrete goal. The concrete goal was improving the overall care, but they couldn't make that leap. They couldn't see that how what we were asking them to do would actually in the long run affect. It sounds like, why not? I mean, it would be very sensible that that would happen, but it didn't. People simply didn't get it. There were underlying continual worries about time and cost. Staff turnover was enormous, enormous. You train these people up in these teams and you get things going, you come back a week later and half of them are gone. Even the practice champions turned over, the physicians. Even at the administrative level, you see people changing over time, especially when you're there from 9 or 18 months. We ran into extraordinary levels of practice system rigidity to use the EHR in effective ways. So even with an intensive, costly intervention, change was significant. We did move them along. It was modest, and frankly, it wasn't sustained. Overall, we, I think, achieved a great deal of pushback. True system change is enormously difficult. As this gentleman is telling his colleague, I want you to find a bold and innovative way to do exactly the same way. I'm mumbling here over words, sorry. An innovative way to do everything exactly the same way it's been done for 25 years. And while it's a joke and we kind of laugh at it, in many ways, these structures are so stressed and so preoccupied with survival in many ways that there isn't a bandwidth. And the thought of changing and putting the energy into kind of moving things around, they just don't have the flexibility to do it as easily as we think or we would want them to. Okay, so that's the lesson from study number 2, and you can see how it varies from FluFit. Let's go to study number 3. This is the study we just finished and just reviewed, around which we just reviewed the data a couple of weeks ago, and I'm getting emails back and forth. We just learned something new. This morning there was a new one. So Miriam is our biostatistician and investigator, and she works at this all night long with this huge data set, and I get emails back and forth. It's kind of neat. Okay, here's the preparation on this. Many patients with chronic disease struggle to meet self-management goals. Surprise. Okay. Interestingly, over 90% of all healthcare decisions for patients with chronic diseases are made by patients, not by clinicians. They're made by patients in the real world in which they live. Self-management support refers to the care and encouragement provided to people with chronic conditions and their families to help them understand their central role in managing their illness, to help them make informed decisions about care and to engage in healthy behaviors. If they're making the decisions, what we really want them to do is know what decisions there are, so they recognize they're making a decision, and do it in an educated way. That's basically, and it's an oversimplification, but I think you get the idea of what self-management support is. So this study, it was called Connection to Health, CTH. It is the 5th generation, and we're actually halfway through recruitment of the 6th generation of this study. The program was initially started by, him again, Dr. Glasgow. What was it, Prescription for Health, Russ? Or before that? It was before. All right, okay. Did the project with Paul Nutting occur before Prescription for Health or after or during? Deborah Tubert. 95 or something. 4-year-old guy, aren't you? 1995, and the program has gotten more and more. It's an web-based automated program, and I'll tell you about it in a second. And it's gotten more and more and more and more sophisticated over the years. And this is the 5th level, so we've increased the sophistication and used it in different ways. So CTH was a 3-arm, again, cluster randomized trial assigning practices, not patients, to test the added value of practice facilitation on the implementation of a structured, web-based automated program of self-management support into primary care based on evidence-based intervention practices for adults with type 2 diabetes. All these are linked for type 2 diabetes because we're all funded by NIDDK, and they like diabetes, so that's our target. There's good reason for that. That's, if there's money there, that's where you got to go to get it. I mean, you can spread it afterwards. You can learn some things that could be applied elsewhere, but they're paying the bills. That's where we go. Okay. It included 36 very diverse primary care practices, half in Colorado and half in the Bay Area. And they were very diverse. We had FQHCs, we had integrated health system practices, we had independent private practices, had a whole range of large and small, urban and rural. We wanted a large and very diverse sample. And again, these were stratified into the three. Once they were stratified, they were then randomized into the three arms. Here are the three arms. And you'll see the similarity with the previous study. The first arm, group 1, was basically what the self-directed arm was in EPIC. We gave them self-management support and chronic care model education. We gave them a web-based program that they could review a huge number of resources about how to improve their self-management support for patients with type 2. And go for it, guys. We let them go. Make sure they had access, make sure they could use their web-based program, and off they went. The second group got all of that. But in addition, we gave them this automated CTH program to improve self-management support. And I'll show you what that is in just a second. So kind of stow that stow that in the back of your. It's an automated clinician to patient program. You go through this together. It's structured and it walks the clinician and the patient through a series of steps to enhance self-management support and action planning and all this other stuff. I'll walk you through it in a minute. All we did for this group was given the program, and we provided technical support for its use. No implementation support. And we said, okay, guys, take your structures, take your system, here, use it, go for it, we'll see you in a little bit. Okay? The third group did exactly the same, but we added one thing more. We added a practice improvement team with a facilitator to help them implement it, and we structured the implementation with them. Okay? So the difference between Group 2 and Group 3 was they both had the program, but in Group 3, we gave them implementation support through a practice improvement team and a practice facilitator. Make sense? Everybody following? So it assessed the added value of the implementation support. That was the goal. Now, what is CTH? Here's what it is. It's an automated web-based program, and here's what it does. It's really, really sweet. It provides a patient assessment. So patients come in, they get a tablet, or they can do it on a desktop, or you can do it on your phone. And it walks them through a series of questions with lots of branching around major areas of management. And I'll show you what they are in the next slide. It then stimulates and spits out a summary report and to give the scores around this assessment, which then the clinician and patient sit down and review. It becomes a conversation starter. And they identify particular problems that they think they should address, and then it leads into an action plan to actually address those problems. Okay, so, and it walks you through step by step by step so that it's a nice flow and it's a very efficient way of doing it, and you're working together, so it enhances the clinical relationship, which is really the core to almost all of this stuff. Here are the 12 things that CTH assesses, and these are all, again, tied to self-management support and the management of type 2 diabetes. And you can skim through those and see all of those. And you can also see, by the way, that there is a whole range of distress, depression, alcohol, tobacco. In this one, in the new one, there is smoking as well. There's not listed on this one, but there's smoking. And social determinants. Thank you. I keep forgetting that one. So we've added in the new one several new assessment areas. Once they take this assessment, here's what they see, which is really a sweet way to do. You see on the left a whole bunch of these areas, and then on the far right you'll see green, yellow, and red boxes, with the red being that's definitely a problem area, the green being it looks like you're doing okay, and the yellow being it could be a problem, it's kind of in the middle. The next row to the left is their scores from the previous assessment, so you can see what changed. Because so much of what we do is not a fixed, static score. It has to do where things are changing. It's chronic disease. You know, people go like this, up and down. And at the bottom, before they complete the task, the web-based task, we ask them, okay, given these problems, which are the ones you want to address? So there are priority lists when you go in and talk to the clinician. So that's basically what you see, and that's the CTH program. The dependent variables, practice culture, staff surveys and interviews, changes in self-management support discussions as documented in the chart, changes in clinical variables like A1C, and we clocked all this through 430 chart reviews across. Now, yeah, exactly. These are very expensive to do. Absolutely the most boring thing you can imagine. Thank God I didn't have to do it. But we had staff who did it and did it really well. So, and the whole thing is dependent on this, obviously. So, and did it in a very consistent way. And it was done, basically we did it at 18 months because chart reviews go way back. So you only need to go at 18 months and you can get all the information for the previous year and a half. Here's what we learned. Of these 36 practices, can you imagine how many type 2 diabetics they had in their practices? Thousands. I mean, just every one had 300, 400, 500 patients, right? Very few were enrolled. That means they didn't do CTH. They weren't brought in and said, hey, we're going to do the self-management. Very, very few. I have the numbers, but it doesn't matter. There were very, very few. Practices with previous CQI experience did better. They enrolled more and they had more documentation. So again, we see this same pattern of where practices come from influences what they're going to do. There were changes in the work culture and change culture as recorded by the staff surveys between groups 2 and 1 and between groups 3 and 1. There were no differences between groups 2 and 3. So where we gave them CTH, the program with or without facilitation, we saw changes in the culture. Clinical outcomes, there was a significant reduction in A1C comparing group 3 with group 1 and group 2 with group 1. And last night I got a note from Miriam, our statistician, saying there is a significant difference with greater reductions in group 3 than group 2. That is, with facilitation, those folks that were in the facilitated practices showed a greater reduction than those who just got the program. And those who just got the programs showed a greater reduction than those who did not. Make sense? Everybody following? Okay. There was no change in blood pressure or cholesterol in any of the group, which doesn't surprise me at all. I mean, some of these things are very hard to change. There was an increase, significant increase, in the SMS discussions as documented in the charts, with significant increases in group 3 in the facilitated practices did we see. So they were using this sucker. They actually used it. They actually enrolled patients in it. They had discussions about it, and there were significant changes as a result of this activity. All enrollments in all 3 arms ceased after 10 months. Done. No maintenance. Zip. 36 practices. Bupkis. Nothing. He's laughing. Do you know, let me tell you, it was like, oh my God, all this work. They didn't carry it on. They left it. Why? There, I think, was they didn't get it. When doing interviews at the end, many staff just didn't understand that what they were doing by working with SMS could really affect. There was no kind of cognitive linkage. They understood the tasks. They did some of it, but it didn't kind of register. Practices were not fully prepared for the kind of change that was required. Remember the no guarantees? Even though you get in the door, no guarantees that they will actually follow through. They weren't prepared for it. Even though we told them, even though we knew what this would demand of them, they kind of accepted it, but they really weren't prepared for it. Huge, again, major staff turnover. You train these people on CTH, they're gone in a month. Well, who's going to take it up and who's going to train them? And it had to be trained by the people in the practice. We weren't going to go back because we were looking for maintenance, right? And what happened was decrease. Interestingly, rather than changing practice structures to fit the program, they try to fit the program into practice structures. What happens? Doesn't work. There's a limit. You know, you can't say, all right, MA, you do this when this happens, or a health educator, you do this when. Well, they can't. They're so occupied with their current role. You can't just add something on. It just doesn't. You have to reconfigure things to provide sufficient time to make it work. That means reallocation of staff. There was a huge tendency to focus on the CTH technology rather than its purpose. This was a tool. That's what it was. It was a means to an end. They focused, as far as they were concerned, the goal was CTH, not what we were working towards. It was hard to find, many of them found, because of physical size. By the way, we were talking about being an anthropologist this morning. Take a look at the rooms, the size of the rooms, the privacy of the rooms, the size of the hallways. Are you walking around like this and people are on top of each other? Just the physical setup often limited having a space that was private to do this work. Just stuff, it's just the nature of the beast. There were almost no patient monitoring. These folks would, with these plans, and they'd see them in 6 months. Even though the program says you need to come back in 2 weeks to check on an action plan, you wasted all that time building an action plan because it's not going to work. You have to bring people back and tweak it to make it play out. You wait for 6 months, it's a done deal. There was no follow-up, as I said, and the CTH system allowed you to record for the entire practice everyone who completed the assessment and what was done. You could record the whole thing for panel management. You could see where people in your practices were having problems with smoking or obesity or whatever it was, and then you can target programs. It's panel management. That's what it's for. No one used it. And unfortunately, the program was not maintained over time. So, CTH was efficacious, but only when it was used. And this slide is actually from Russ, who says if an intervention works and nobody can use it, does it still make an impact? And it's like the forest and the trees and if somebody. Okay. All right. So we were talking about reflections. Let's talk about reflections. Given these 3 studies, okay. So here's some thoughts I have, and I'm playing with these thoughts and trying to be generative with them. Okay, so follow along and see if they make sense, and they may not, and that's okay. It seems to me, when we're doing implementation research, like these studies, we need to consider 2 targets for any effort. The first is the complexity of the program, and you can see how FluFit, EPIC, and CTH vary considerably in complexity. And that has to do with the demand characteristics of the program itself. The second thing we need to look at is the capacity of the practice as a system to do what the program calls for. Now, I'm not talking about can they press this button and move this along and check that. I'm talking about the systemic characteristics of the practice, of the organization, of the health department. Do they have the sufficient flexibility and skills to manage the change that's going to be required? So you have program complexity and practice capacity. Okay? 2 things. The crucial question, given the complexity of any new program, does the practice system have the capacity to handle the changes demanded by the program? And not just the tasks, but the systemic characteristics to manage the program. And so what I did was to suggest that we need to match program complexity with practice capacity. Boy, that's a mouthful. Program complexity with practice capacity. Otherwise, we ask practices to do far too much, and we increase the probability of a failed implementation and failed maintenance. I think we ask practices to do too much. There is no question going in hundreds of practices. We're just asking for too much. We underestimate the level of complexity, practice change capacity required for implementing most new programs. And here's a way of thinking about it. Let's graph program complexity on the horizontal axis. So as you go out, there are more and more complex programs, okay? From FluFit on the left to, I don't know, EPIC or CTH to the right, okay? And on the vertical axis, let's talk about practice capacity. Now, practice capacity excluding any emergent goals like your rent went up 50%. Or the feds are saying you have to do this and that tomorrow. So the crisis stuff, take that out. We're just talking about the kind of general system capabilities, capacities. Okay? It seems to me that successful implementation is based on this line. Now, what I did when I originally drew this line was to make it linear and have it go right up the center. And the more I realized I did that, the more I thought about it, I said, that doesn't make sense. I think what happens is the need for capacity increases geometrically as you go up the dimension of program complexity. And that's because we don't realize how much capacity is required even for gradual increases in program complexity. So FluFit is way down on the bottom, and I just threw CTH and EPIC in this way, especially EPIC, the RAP groups were looking at system change. Remember that one, that arm? Really way up at the top. So it means, what I'm trying to emphasize here is that not all programs should be introduced to all practices. I mean, and that's a given we don't think about. And the reason that's striking for me is when we're out recruiting practices to participate in these trials, we are desperate. We'll take anybody willing to jump in. Thank God we're going to have enough to fill our cohort. But we don't have the luxury of thinking about, can they really do this? So we've got to match the complexity of the program with the capacity of the practice, and that means not all practices should be introduced to all programs. Programs need to be tailored to fit practice characteristics, and some practices probably should be excluded because it's a setup for failure. We need better ways, then, of assessing practice capacity, and there are ways out there. There are the building blocks, Bodenheimer's building blocks model, there's COM-B, Cypher, and there's the Solberg model. There's a whole mess of, they're not as explicit as I'd like, but they're out there. I mean, they're around, you know. And I think what we really need to do is be developing better methods to assess practice capacity so we'll know which programs will fit the best and where we'll get the best match. So here is an exercise with Albert. What we do is ask ourselves what kind of implementation strategies we might consider to get more efficacious programs into clinical care, given this complexity capacity argument. So what I tried to do here was come up, okay, given this, what kind of strategy could we adopt? And many of these are off the wall. I would never do them, but I'm trying to expand my brain. See what you think. Some of them are kind of crazy. But if we buy this notion, then these are the kinds of things we might want to consider. So I'm going to ask you to stretch your brain, and let's take a look at these 7. One thing we could do is select only practices with high change capacity. Why work with these others? We're set up to failure. It's not going to work. Of course, there's the problem we're going to increase disparities among practices. You know, the good ones are going to take off, and the ones that are problematic are going to sit there. But if you're doing an efficacy trial, not an implementation trial, if you're doing an efficacy trial, that's not a bad strategy because you have a better guarantee they're actually going to do it, and you'll find out whether the sucker works. Right? Make sense? Okay. Second strategy. Engage only with health systems with strong, committed, top-down control, like Kaiser or the health system in Utah that completely changed itself, reconverted itself into a chronic care model program in about 4 or 5 years, or 6 years, and it did a beautiful job. But you know how they did it? Like Kaiser, CEO, they had all the chiefs, this is the way we're going to do it. And they own the system. They pay the bills. And either you did it or you left. And very few people would leave because they're vested. You know, they made sure the incentives were there to keep people. They got a lot of pushback. And that's how Kaiser changed from an old acute care model into a team care model, by creating clinical team. They disrupted the whole system by doing it. But it was set up by upstairs, under control, and they were able to do it. Third option, actively partner with practices at the beginning to build a desired program from scratch. This is a fascinating idea. How many of you go into primary care or other systems with a program? We all come up with programs. They're efficacious. We got, hey, you guys ought to use that. Well, wait a minute. There's another way of doing this, and that is, why should we be doing all the work? Why don't we join with a practice with an idea and then together build something from scratch that will work in that setting that the practice can own as theirs, rather than coming from outside with something we are added that those from inside see as coming from outside. And there is a group that has done it. It's headed by Jewel, and they've just published a very interesting report of this strategy. It takes a longer period of time. It's tricky to do, and of course they can kick you out and say, hey, we're on our own. We don't need you to do this. And then you've lost the implementation part, but that's a strategy. You don't come in with a program. You come in, engage the practice or the organization in the idea, and you build it slowly together in ways that actually fits the resources and the systemic nature of that program. 4, Create a program with multiple components and ask the practice to select only those that might work for them. Great idea, but sometimes it's kind of hard to have programs with multiple independent programs where you can do that. But worth considering. Do a comprehensive practice assessment if you can, and determine if a practice has the capacity to manage a program with a given level of complexity, and then only introduce the program to those. That's great. It'll ruin your reputation in the community. Absolutely ruin it in the community, because you're assessing practices, you're engaging them, and say, oh, sorry guys, we can't do it here. The word will get out, not a good move. But in terms of actually completing the implementation trial, it's not an unreasonable thing to think about. Okay, 6, start with low-capacity programs in low-capacity practices and increase complexity incrementally over time with collaboration. So match these low-capacity practices with low-complexity, really simple programs. They're not going to be the greatest thing. The clinical change probably isn't going to be the greatest, but get them engaged and then slowly move them along with more and more work. A lot of this coming from them as they see the benefits. And do it jointly. And last, what you could do is take all practices and provide massive levels of practice facilitation to increase practice capacity. Good luck with this. It's been done up to 2 years with very minimal results. But it has the potential, if you have the right kind of practice capacity techniques, perhaps. It's worth considering. What can we do from the outside to increase practice capacity? That's a legitimate question. I don't know the answer to it, but it's something that we might want to consider. We desperately need more creative ways to address the frequent mismatch between program complexity and practice capacity to increase adoption, implementation, and maintenance. So here are the take-home messages, and I'll stop. Design programs with implementation and maintenance in mind from the beginning. Don't start with the program. Start with the target of the program. Match program complexity to practice capacity. Don't ask them to do too much. It's a risk we all run into. Explore efforts to better assess capacity. We need to do much, much more of this. Recognize the uniqueness of each practice system. If you've seen one practice, you've seen one practice. It does not necessarily generalize. And oh, by the way, if you go back to that practice 6 months later, it may be very different than the practice you saw 6 months. Recognize that implementing new programs in primary care is really, really really tough. That's not to turn you off. It's recognizing the reality, and so you're prepared for it and don't get discouraged. In the past, the task was to develop efficacious programs. I would suggest to you that our current challenge is to get them adopted, implemented. And frankly, we have a ways to go when it comes to that. Thank you.
Well, we're a little bit over our time, but if people want to stay and chat for a bit.
Any comments first? I'll be standing around. I'd love to get your thoughts, especially with your very different perspective on something. Anybody have a comment you want to raise now, or we can talk privately, whatever would be best. Any thoughts? Yes, ma'am.
I think some of the record-keeping requirements imposed by CMS, which is this big background task thing going on, and then we come in and try to do something, it just feels like more of the same, and there's almost a existing, this is not what I trained to do. I don't want to do this. I don't have an MBA. I'm not an accountant. To the point that some of those data sets are trash because even physicians are just like flicking to get through the screen, like, you're driving me nuts.
Who are we talking about? EHRs? You know, the massive amount, they're over-informed.
Some of it's so ill-directed that it's, anybody that's coming in is kind of working with this, are you one of them, or is it the same or more?
Are you one of them? You know, one of the things that Joe mentioned this morning in our discussion is in doing this work, it may really be helpful to think about being an anthropologist, of going into these settings, organizations, not just practices, organizations, and getting a sense of how they are operating, who talks to whom, how the power structure operates, how the flow is. Is it easy? Is it jerky? Is it missed? Who does, the really kind of, who's in the lunchroom? Who sits with whom? How powerful is the office manager? Really powerful. That kind.
Definitely an influential others thing going on as far as like how hard are we going to try on this?
That's right. Once you get that sense, then addressing these issues, I think, makes more sense because you have a sense of what they're struggling with. But you're absolutely right. These are constantly, these folks are getting pounded, all the time. My primary care doc was petrified about a month ago because the office building they were in, the realtor called them and said, "Oh, you know the huge hallway that runs by your office outside by the elevators? We are now calculating that in the square footage that you have to pay rent on." And it knocked them for a loop. And the reason was they didn't have the money. It was a huge amount of money. And they were trying to figure out who would have to go to pay for that. And it was like everything came to a stop. Everything, because their survival was threatened. And here we're bringing in a program, be nice to your patients in this. Okay, so it's not that that's the nature of reality. How can we work with that reality and still help them improve care? So you're absolutely right.
Have you had any experience with policy to change incentives and or motivation by the practice itself? So I'm thinking right now about the kind of peer organizations in Oregon called CCOs, where the focus on improving population health is being built into metrics.
Yeah.
That feeds into implementation.
Yeah. One of the quotes, it has a potentially wonderful effect. It's getting from here to here and the disruption that it causes. And sometimes the disruption is incredible. When, what was it in California where you would pay for performance? All of a sudden, things changed. And then they changed right back. And the reason they changed right back was the docs realized that the effort that it would take to change the practice to get that extra money wasn't worth it. So again, it's understanding the incentives and what the cost of it, the real true cost was going to be. It wasn't worth it. So a lot of them said forget it. A lot of them took it up, but many of them said it's not worth reconfiguring everything to make that happen. It's not enough money. It's really not. So again, it's understanding the system. Any other thoughts before we stop? Yes.
Just a quick perspective as you close up here so you don't beat yourself up or our whole field too much about, everything you said is right on, I think, and the challenges are mistaken. But to put it in perspective, the human genome was sequenced a little over 20 years ago now. Francis Collins, the NIH director, promises
Your conference is scheduled to end in 2 minutes.
change. So maybe 15 years isn't that bad for the deep.
Exactly. I think the issue here is not
to say that this is impossible. It's recognizing what the issues are so that we go in and do this work, because we all think it's important. We're still doing it. So, but it's recognizing the roadblocks and helping you anticipate them so that you'll have some perspective and figuring out how you're going to negotiate. If you don't do this, you really get scrunched, and then you get depressed and you feel like, oh. Anyway, thank you very much. Appreciate it.